Grazie. I know many of you are in transition. I don't know how I got this lucky spot of being the last speaker after such a long list of esteemed speakers today, but I appreciate your staying and your attendance. It's an honor to be here. I am from the U.S. Centers for Disease Control and Prevention, and I'm going to talk a little bit, if I find the pointer. This is kind of a step backwards to some degree, but some of the reasons why we are all here are because of the concern. Whoa, I don't know what I did. Sorry. If you're not awake, you are now. Okay, so like I said, this is somewhat of a step backwards because the reason why many of us are here is because of the concerns about increases in the numbers of people with autism. And how do we know how many people have an autism spectrum disorder is a challenging issue. Seems like a simple question, but it's a little bit more complicated than we give credit to. And so we certainly know in the U.S. that, I'm not sure how to use a pointer, but in the U.S. these are some data from our service systems. One, the California service system that Eric just showed some data from, and the public education system. So these are both free service systems and have been seeing large increases in the number of children with autism starting in the 1990s and forward. And I imagine and heard reports of very similar things happening in Europe and other places in the world. So how do we know how many children there are? One thing we can do is to look at data from these types of service systems, and that tells us which children have been identified as having autism and have come to the attention of a service provider to get some sort of intervention. But we know that there are other children. Certainly when we're talking about adults, that's a very common issue of how many adults are out there who've never been identified before. But the same issue still holds true among children. So besides those children who've been identified, who else is out there? And there are different methodologies that have been used to look at the wider population of the number of children not just identified with autism, but that who may have the symptom constellation that makes up the autism spectrum disorders. We've heard a lot of promising talks today about the future of biological mechanisms and biological markers, but we're not there yet. So right now we have our eyes and our experience of working with children and understanding their development to identify autism. So some of the methods that we can use are to do direct population screening. This is certainly considered a gold standard, but one, you have to have access to a large population where you can actually conduct the screens, follow up, do the evaluations. That's quite costly and time intensive, but there's also some cons in terms of response bias and who actually participates in that level of in-depth in that level of in-depth assessment. In the U.S., we don't have a comprehensive screening system in place at this point to really utilize that type of method. There's also been studies that have just asked parents, has your child ever been diagnosed with autism? And there's issues with validation there, really knowing what do they understand about the diagnosis, what does it mean to them. Another method has been to take the symptoms described in the developmental evaluations and to look at a profile of a child's developmental history based on those evaluations, which is a records-based system. Now, in a setting where you have access to various service centers like we do in the United States, it is possible to use a records-based method. So I'm going to tell you a little bit about that. So in general, one thing that we see in autism, we always want to, certainly the media does this, is point to the one number. How many children, tell me exactly how many children have an autism spectrum disorder. As we've been talking about the heterogeneity, we know there's variability in the expression of autism. And so teasing apart the numbers from what may be natural variability among the set of disorders versus what may indicate some sort of different risk. Do we have a different prevalence in one area from another area because we're really talking about a different risk in certain areas? Or is it because of some of the natural heterogeneity? Or is it because how children are identified in those areas? So it's a lot to tease out so we can get to that question of how much of these increases that we're seeing are due to environmental factors that Eric just reviewed very nicely, or other factors in terms of risk, or is this an identification issue? We've kind of pulled this debate apart where it has to be one or the other, and that's way too simplistic. Where we need to be now is looking at the multiple factors that may be contributing to the increases in autism. So in terms of, although there always is a range, the best estimate summaries have been prior to the 1990s from the first EPI study in the 1960s. We're about 1 in 2,000 children. Often we cited this as about 4 to 5 per 10,000 children. Now that was also primarily looking at autistic disorder. And as Eric pointed out, in the 1990s, we saw these big increases in autism prevalence. But that was also when we really started to incorporate the idea of the spectrum. And so updated estimates using more modern criteria were initially about 1 in 500 in the 1990s to about 1 in 150 in this past decade, and even more recent studies showing about 1%. So at the CDC, we're the public health agency for the United States. We use this model where we're trying to look at statistics, help that inform our studies, give us clues to risk factors, and at what point can we have some sort of prevention. Now, in the case of autism, as we've heard a lot today, our best prevention is preventing the long-term debilitating symptoms, which is identifying children early and starting intervention. So these processes inform each other. And we have multiple projects. One I'm going to be talking about is the Autism and Developmental Disabilities Monitoring Project, the ADAM network, which is the primary way we've used to collect the statistics on the prevalence of autism. But we also have risk factor studies as well as a public education campaign about early education. So the ADAM network, it's a collaborative effort of multiple sites across the United States. Across our states, we have a lot of variability in terms of how services are provided, how children get evaluated, but there are some commonalities. So we're trying to capture and take advantage of those commonalities, use a similar methodology in these different sites, and see what the variability is, and see how this changes over time. So as I mentioned, we use a records-based system. We get information on children who are age 8. So we're doing basically cross-sectional looks of children at age 8. And the reason we've picked age 8 is because we found that that's really when we found the peak prevalence. We identify most kids at that point. We're hoping in future times we'll be able to look at very younger ages, but we know at this point that's an underestimate, but we're working on that right now. So looking at children at age 8, trying to get the full spectrum of the autism conditions. We look at multiple sources of information, so children where they were evaluated through developmental pediatricians, psychologists, psychiatrists, speech pathologists, or through the public school systems. And then we take this information and build a profile on a child. So the child does not necessarily have to have already had a diagnosis of autism. We go through painstakingly records one by one and look for any social behavior that could be related to autism. So if we see in a child's record who was evaluated, say, for an intellectual disability, it makes a notation of poor eye contact. That child would be flagged as somebody that we need to put this profile together, find all of their records, look at their history of evaluations, and then we have a separate set of clinician reviewers, people that are experienced in clinical practice and have participated in research and have become reliable with one another in terms of evaluating the information in these records using the DSM-4 criteria. So we have an independent identification of those symptoms and the early delays. So the first report of the ADAM network, and in the United States, people look to the CDC a lot for, what are the numbers of people with asthma, with heart disease, with cancer. And so similar as autism, in the case of autism, the CDC's data comes from the ADAM network. And the first report was published in 2007. Indicating a range of prevalence from 1 in 100 children to 1 in 300 children with an autism spectrum disorder, with an average of 1 in 150. We had a more updated report from this past December, and here we found a range. And this is a retrospective review of children, and I'll explain that in a minute. But the latest report in 2009 covered about 8% of the U.S. population of 8-year-olds. And it was in 11 different states in the United States. And we did see some variability again, from a low of 4.2 per thousand, or about 1 in 240 children, to a high of 12.1 per thousand children, about 1 in 80 children. The average across these sites was 1 in 110, or 9.0 per thousand, roughly equal to about 1% of children being found in other studies. What was more surprising, actually, though, was that the majority of sites really did cluster in a tighter range, from about 7 to 9 per thousand. We found the common pattern of more boys to girls, about 4.5 if you can have 0.5 of a boy, but 4.5 boys to every girl. We also did find one of the advantages of our population is that it is heterogeneous in terms of race and ethnicity. So we did find a difference in terms of white, black, and Hispanic children, with a higher prevalence among white children when you look at the averages. But we didn't find this in all sites. When you look more closely, there are several sites that had equal prevalence across these different subgroups. And so this is where, as we look at these populations over time, we're seeing an indication that we're seeing increases in prevalence, in particular among Hispanic children, giving us an idea that this may be more of an identification factor and what gets documented in their records more than this is a difference in etiology. One of the other things that we look at is what are the first concerns about these children's development, and we found for the majority of kids, between 70 to 95% of kids that we said had evidence of an autism spectrum disorder at 8, somebody was concerned about their development before the age of 2. So it's important to remember that this is a very large population of almost 3,000 kids, in the general population. Not just a high-risk sample to some degree. It's somewhat of a high risk that these were children who've been evaluated to some degree, but it's a little bit broader in terms of they're not children who already had a sibling or who may have necessarily been identified specifically with autism. So the majority of these kids, somebody was concerned about their development. Typically, it was about their language development before the age of 2. And we did have a report of about 13 to 30% of developmental regression. Now, I think that's important to note that that is a report, and we've heard some really good evidence today about, is this really a true regression, or is this more of a plateauing of skills, or not a frank loss of skills, but a deceleration to some degree. But we also found that there's still quite a delay between the average age of diagnosis. So the average age was 4.5 years. Depending on the site, it ranged from about 3.5 to over 5 years of age. And we do find that children who were diagnosed with subtypes such as Asperger's disorder had a later age of identification. Most children were receiving special education services through the public school. We have a law that requires that any student that has a special need related to their education gets evaluated and is given a free, appropriate education. So not all children are in special education, but upwards of 90% in many of the sites. But many of the children were not classified under an autism eligibility. So to get special education, you then have to be eligible under a specific condition. And it doesn't necessarily mean if you have autism that you're classified under autism. So a lot of people have used the United States education data to look at changes in prevalence over time. And I would just be cautious about that because it tells much more about service differences and use of that label than it does about the true underlying number of children with autism. Another thing that we looked at, now that we have multiple time points, this was our first effort to really say, okay, in these same areas of the U.S., what was the change in prevalence in these different 8-year-old cohorts over time? So we looked at children who were in the years 2002 and 2006. They were born in 1994 and 1998. So now we have multiple time points, and we can go back and we have a time point starting in 1988, and then 92, 94, 96, 98, 2000, and forward, where we're reconstructing these cohorts of children born in the 1990s and forward. So now we can go back and start to pick apart, what is changing in these populations and give us some more ideas about the reasons for the increase.